This lecture is on the pharmacotherapy management in burn patients. The objectives of this burns lecture includes learning the risks and complications in burn patients, how to manage fluids, identifying essential treatments that are needed, and understanding the role of a pharmacist in burn patient management. This is an outline of what will be covered in this lecture. Burns are the fourth most common type of trauma in the world after traffic accidents, falls, and interpersonal violence. It is less common in Hong Kong as low to middle income countries have a higher prevalence of burn rates. In high income countries like Hong Kong, men are more likely to have a severe burn than women. As you would expect, you will see more burn patients in the winter than in the summer in most countries that have multiple seasons due to heaters and such. The rate of mortality in burn patients is directly correlated with the severity of the burn. TBSA is total body surface area. The more of the TBSA that is burnt, the higher the mortality rate, especially once you exceed 50% of the TBSA. The mortality rates in the table are on this slide. They are from the United States, but it is probably quite similar to Hong Kong. We will talk more about how to calculate TBSA shortly. Which region has the highest rates of burns that require medical care? The answer is B, Western Pacific and Southeast Asia, including China. There are several different types of burns. Scalds, or a burn from a hot liquid, make up about 70% of pediatric burns. Burns from an open flame make up about 50% of burns in adults. Electrical burns are much more rare, however, there are two types of them. A true high-tension burn is where the electrical current passes through the body, whereas a flash burn does not pass the body, but nearby electrical current arcs burn the patient. A particular concern after an electrical injury is the need for cardiac monitoring. There is good evidence that if the patient's ECG or electrocardiogram on admission is normal, and there is no history of loss of consciousness, then cardiac monitoring is not required. If there are ECG abnormalities, then the patient needs to be admitted to the hospital and be monitored for no less than 24 hours. You should also watch renal function and signs of rhabdomyalgia in patients with electrical burns. When it comes to chemical burns, burns from alkalis are worse than burns from acids because they penetrate deeper. Cement would be the most common alkali burn. Hydrofluoric acid can cause particularly deep burns that may not become symptomatic until after some time of exposure. In general, when dealing with burns, tissue destruction is related to the temperature and duration of exposure. As you are all probably aware, burns are classified based on degrees and present differently. A first degree or superficial burn will have a red appearance and will heal in about 5 to 10 days. With progressing severity, healing time increases dramatically and appearance changes from red to white to brown to black and charred. You will see a systemic inflammatory response with burns greater than 30% of the TBSA. Risk factors of mortality in burn patients include age, burn severity, and inhalation injury. The more of these risk factors a patient has, the more likely they are to die. First degree burns are your general sunburn. Second degree involves the dermis. Third degree burns involve the subcutaneous tissue. And fourth degree involves the muscle or bone. The pathophysiology behind burns is complex and complicated, including release of histamine and other inflammatory mediators. Hypovolemia also occurs due to increased capillary permeability from the release of vasodilation mediators. Coagulation pathway activation also leads to microvascular thrombosis. Maximal edema occurs at varying times based on the severity of the burn. Edema occurs in both burned and unburned tissue. Other reactions that occur in the body of a burned patient include heat loss, increased evaporation of water, glucose intolerance, and decreased pulmonary function. The second question is, what is the most common cause of death in burn patients? The correct answer is infection, most commonly pneumonia, cellulitis, and UTI, or urinary tract infection. Burn patient management is largely assessing and treating complications. The most common complications in addition to infections are anemia, thromboembolism due to increased coagulation factors, hypermetabolic state leading to decreased bone density and a loss of muscle mass, increased risk of rhabdomyolysis, post-traumatic stress disorder or PTSD, and scarring, which can lead to anxiety and issues with body image. When calculating TBSA, first-degree burns are not included. Most burns, 70%, have a TBSA of less than 10%. For adult patients, we use the rule of nines, which is distributed as shown in the graphic here. Also note that the front of the hand is approximately 1% of the TBSA, so you can use that as an estimation tool as well. This only applies to those over 16 years old, as proportions are different in those of younger age, especially the size of the head in infants. Which patients should be admitted from the emergency department to the hospital rather than being discharged for outpatient management? Patients that should be admitted for more intensive therapy and monitoring include infants, second-degree burn of greater than 10%, or third-degree burn of greater than 5%. Also, consideration for admission should include those with burns to sensitive areas and inhalation injury, as well as a few others. Emergent treatment is primarily about airway protection, including treatment with salbutamol and possible intubation. Many medications are used during an intubation, including a sedative such as etomidate or benzodiazepine like midazolam, and also often used is a paralytic agent, most commonly succinylcholine or alternatively rocuronium. Succinylcholine does have the side effect of causing an increase in potassium release from the cells. Also, burn patients have an increase in potassium release from the burn cells. This causes concern over having an elevated potassium level. However, the potassium release from burn cells does not result in an elevated serum potassium level until after 72 hours from the initial burn. So succinylcholine would be okay to use for the first 72 hours after a burn. Steroids should be avoided in these patients due to increased risk of bacterial infection, as well as delayed wound healing from steroids. Another important staple of burn patient management is fluid management. These patients become rapidly dehydrated. Lactated ringers in the United States and Canada, or Hartmann's solution in the UK, are the preferred fluids, due to them being more closely resembling physiological components, providing less risk for hyperchloremic acidosis than compared to normal saline. There are several formulas that can be used to estimate fluid requirements. One of the more commonly used formulas is the Parkland formula. It is 4 milliliters per kilogram times the percent of TBSA burned. 50% of the calculated dose is given in the first 8 hours, and the remaining 50% is given over the following 16 hours. Formal fluid management using the Parkland formula is generally used when TBSA from burns is greater than 15% in adults or greater than 10% in pediatrics. This table is to compare the components of each of the 3 commonly used IV fluids. The bolded and underlined values are the ones that more closely resemble the body's intracellular fluid. As you can see, lactated ringers much more closely mimics the body's fluid than normal saline or glucose or dextrose 5% in water. Galveston is a common equation used in pediatric patients rather than the Parkland formula. It is important to continuously monitor the fluid status in patients, and hourly urine output should be maintained at 0.5 milliliters per kilogram in adults. In general, blood transfusions should be avoided in these patients who are already at high risk for thromboembolism until their hemoglobin level drops below 8 grams per deciliter, or if they have another compelling indication for a blood transfusion. It is also recommended to avoid use of diuretics, particularly in the acute phase, to improve urine output, as diuretics greatly decrease the intravascular volume. Other measures that should be done in burn patients is to cool the burns, as cooling the burns reduces burn depth and burn pain. Pain and anxiety management should also be addressed. Tetanus immunization for burns deeper than superficial thickness is recommended for patients without a tetanus vaccination in the past 5 to 10 years or an unknown vaccination history, as per the World Health Organization recommendations. Tetanus is caused by the bacterium Clostridium tetani, which produces toxins that attack the nervous system. The disease is characterized by painful muscular contractions at the jaws and the neck. The trunk is sometimes also affected, and generalized spasms of muscles may occur. When tetanus affects muscles that help to breathe, the patient can die very quickly. The incubation period for the bacteria is between 3 to 21 days, most commonly around 10 days. Topical antibiotics such as silver sulfadiazine, bacitracin, or triple antibiotics may be used. And if the patient has carbon monoxide or cyanide poisoning, hydroxycobalamin should be used as a cyanide antidote. Carboxyhemoglobin level should be obtained in all patients with moderate or severe burns, as symptoms are very nonspecific, including dizziness and headache. This table should not be memorized. It is purely to show you that depending on what substance was burned, different toxins will be released in the smoke, resulting in various symptoms and effects. Numerous hypermetabolic changes occur in severe burn patients, including protein and lipid catabolism or breakdown. There are increases in secretion of glucocorticoids, catecholamines, and glucagon. Energy expenditure dramatically increases and body temperature also rises. There is peripheral insulin resistance, resulting in higher blood glucose levels not only from the increase in glucocorticoids. Also, as mentioned earlier, infection risk increases. Hypermetabolic changes generally begin within 5 days after the severe burn and may last up to 12 months. As expected, the larger the burn size, the more significant increase in metabolic rate is seen, with 15 to 25% of burn patients experiencing impaired immunity and significant fluid shifts. With 25% total body surface area burns, the patient's metabolic rate will be increased anywhere from 118 to 210% the prior basal metabolic rate. Once you reach 40% of TBSA, all patients are hypermetabolic, and the rate of being hypermetabolic will slowly decrease over the next year. There are two phases in the body's initial reaction to the burn. In the first 24 hours, the metabolic rate is slowed. This is the ebb phase shown in this graph, with impaired glucose tolerance and hyperglycemia. Then, between days 2 and 5, there is a gradual increase in metabolism and insulin resistance progresses. Other treatments that should be done includes the excision of necrotic tissue. This has greatly improved mortality rates in burn patients. Deep vein thrombosis or pulmonary embolism prophylaxis should always be assessed in these patients. Although burn patients are not explicitly stated on DVT risk scoring systems such as the Padua, Geneva, or Improve risk scores, it may be considered as a trauma patient or being immobilized for greater than 3 days. Long-acting opiates for pain management, such as methadone, are commonly needed due to severe pain levels and the long duration of pain the patient will experience. One should also consider the use of anxiolytics for patients with initially high pain scores. The shock from burn injuries results in vasoconstriction of the gastrointestinal tissue that may result in gastric distension, ulcers, and aspiration. Nasogastric tube should be considered for burns greater than 20%, and medication for gastric acid suppression should be heavily considered, including H2 antagonists or proton pump inhibitors. Enteral feeds should begin within 24 hours, as that has been shown in studies to improve outcomes in burn patients. Burn patient diets should include low-fat and high carbohydrate components. One method to combat this rapid protein and lipid breakdown in burn patients is initiation of an anabolic steroid. Oxandrolone is commonly used in the USA, and nandrolone is the preferred anabolic steroid in Hong Kong. These anabolic steroids have been shown to enhance protein synthesis efficiency, reduce weight loss, and increase donor site wound healing. These are expensive drugs, but are expected to be worth their cost due to their ability to reduce hospital length of stay significantly by 11 to 12 days, and benefits can be seen in patients up to 5 years later. These steroids require monitoring of LFTs or liver function tests, lipid panel, INR or prothrombin time, and the complete blood count or CBC. In comparison to testosterone, oxandrolone has tenfold higher anabolic effects and only 10% of the androgenic effects. However, due to androgenic effects still present, it is listed as pregnancy category X and should not be used in this population. Caution should be used in patients with heart failure as well. Recombinant human growth hormone has a limited role in burn patient management. It can be utilized in pediatric patients during the chronic phase only. The only consistent and significant benefit was that it increased height velocity in children. As you can see by this graph, endogenous human growth hormone declines most rapidly between ages 10 to 30. Using it in adults does not provide much benefit because their levels of human growth hormone already remain low. Use should be avoided in all patients with infections. Use of human growth hormone does require blood glucose monitoring as it increases the risk of hyperglycemia by 2.65 times. Insulin is generally used for the hyperglycemia associated with burns due to the erratic and highly fluctuating nature of the hyperglycemia. But metformin may also be used as it rarely ever causes hypoglycemia when used as oral monotherapy. Another agent that should be used is propranolol for 1 year. It works by decreasing the stressful effects of catecholamines and cardiac oxygen demand. Although supporting evidence is stronger for pediatrics than adults, we use propranolol for both populations. There are currently some major ongoing studies looking at the beneficial effect of propranolol. Clinically, propranolol may decrease infections, mortality, and help with wound healing impairment. You may see several other therapies utilized, but they are not supported by clinical evidence, including honey, aloe vera, oatmeal, and numerous vitamins. So, what is the role of a pharmacist in burn care? Primarily, pharmacist involvement includes management of fluids and electrolytes, ensuring appropriate use of metabolic modulators like propranolol and nandrolone. Also, comprehensive care should include assessing nutritional status and confirming that appropriate nutrient products are being provided, recommending and de-escalating antibiotics, adjusting glycemic control, and identifying the need for DVT and stress ulcer prophylaxis are also responsibilities of the pharmacist. The third and final question: which of the following are acceptable parameters to maintain when evaluating fluid resuscitation? The correct answer is E. All of the above are appropriate monitoring parameters. Lastly, I would like to provide some counseling tips for pharmacists who are treating patients that are to be discharged or are being seen in a community pharmacy. It is most important for a community pharmacist to know when to refer to a physician. The situations when to refer are listed in this table, including patients with weakened immune system, as an example, a transplant patient or a patient with HIV, patients with significant cardiac, lung, liver, or diabetes diseases, elderly and small children, patients with severe burns, chemical burns, or electrical burns, patients with inhalation injury, or with burns in sensitive locations such as the genitals. For minor burns that can be managed by a pharmacist, the first thing you should do is to remove any clothing or debris from the burn site. Next is to run cool, not ice cold, but cool water for less than 5 minutes. Soap is okay to use. Patients should be advised not to pop blisters, as that increases the risk for infection. Paracetamol or NSAIDs may be used for pain, barring any contraindications. Patients should not apply sunscreen on top of burned skin. Creams are okay to use to help the skin, as long as it is non-perfumed moisturizing cream, such as Vaseline Intensive Care, Eucerin, Nivea, mineral oil, or cocoa butter. Patients should not apply over-the-counter topical steroids or silver sulfadiazine, and also diphenhydramine oral may be used to help relieve itching. That concludes this presentation. Thank you.